Hello, everyone. Welcome back to Hot Seat. I'm Omid Moghaddas from Tehran, and I'm so grateful again to be with you all from this educational platform. And I have to say, I'm so thrilled and excited to have a very dear friend, the master clinician, Georgios Kotsakis, is here with us in the United States. Hello, Georgios, and welcome to Hot Seat. I'm so grateful to have you with us, my friend.
Well, Omid, it's a great pleasure for me, and I've been one of the enthusiastic fans of season 1 of the Hot Seat, and I saw these people that are really either my role models or my contemporaries going through, and just I'm very excited about what you've built here, because I'm a lifelong learner myself, and what I see you've done here is you've really captured the current beat of implantology. And I just enjoy so much what's in the hot seat and kind of exchanging, like intellectually stimulating and getting ideas about what's hot right now in dentistry. So terrific pleasure to be here from San Antonio today in your hot seat.
Thank you so much, my friend. The pleasure is mine. Well, as all of our audience know, we try to cover almost every aspect in implant dentistry today. And what could be hotter than peri-implantitis? That it's, I think, I'm sure it's one of the topics that everyone will be involved in it, if not yet. And it's something that we should have enough knowledge to be able to manage our patients properly, and what should be the decisions that we should make when facing our patients, facing the problems. And these are the things that my dear friend gonna cover for us today. And before we start, I'm not gonna go to the details. I'm pretty sure he will show us so many great stuffs, but as a tradition, first, I would like to have a CV of Georgios for all of you. I'm pretty sure most of you know this gentleman and his great work, but tradition, I will have his CV for you guys. He graduated in dentistry with his dental degree at the National University of Athens. Then he had his certificate in periodontology and master degree from University of Minnesota. And also he became assistant professor at this university and also University of Washington, Seattle. And currently he's an associate professor at the Department of Periodontology at the University of Texas Health Science Center in San Antonio, Texas. And I have to say that he is also one of the authors of Newman and Carranza's Clinical Periodontology, and he had a chapter about the recent pre-implant disease classification that I believe that he will share it with us today. So I'm super excited again, and thank you again for accepting. I will not talk longer than this, and I will give you the platform, and I think we will have a short discussion together. Thank you.
Absolutely, totally. Let me just start by sharing my screen here with you all. All right, cool. Are you able to see the screen okay?
Yeah, perfect.
Perfect. So, Omid, I think you kind of captured this topic very nicely, because peri-implantitis and peri-implant complications in general is such a hot topic today, because we've actually come to the realization that implants, being so tremendously successful as they are, they don't come complication free. And that's a thing that has bugged me since my times, pretty much. I did a residency at the University of Minnesota, and it was one of those things where, you get into a residency program, you need to have training to be the best that you can be and really kind of have a solution for everything when your referring dentists come to you, right? That's kind of the job of the specialist. And when I was training, it was kind of synchronous with the time with the realization that peri-implantitis is a very big problem. It was shortly before the kind of the seminal paper from the University of Washington showing up to 25% prevalence of peri-implantitis in the US. And I getting my first peri-implant cases as I was getting close to the end of my program. It was implants that I had placed in my first year, and by my third year, I already had complications. Lo and behold, I would go to my faculty and to my program director and ask for instruction, and there was none. The textbook on peri-implant diseases and complication hadn't been written yet. So really, it was unexplored territory, and we would do crazy things. We would use burrs to grind off things like implantoplastic. We would use chlorhexidine, any strong chemical we would think of, and unfortunately, pretty much everything would fail. So I kind of took up this challenge, and I said, okay, I have one of my favorite paintings here by Caravaggio. It's the Tooth Puller, and it kind of shows us how we've transitioned from a very technical profession, as dentistry has been for decades, to this era of implant dentistry, where you really got to think, I feel, science and biomechanics above techniques. And that kind of urges us to go back to the drawing board. And that's what I've done for many years. Now it's culminated into my lab here at the UT Dentistry San Antonio, and my practice being primarily focused on treating peri-implantitis and peri-implant complications, where we really have gone back to the drawing board and we've rethought how implants integrate, how they lose this integration, and how we could possibly re-osseointegrate them. So it's been an amazing journey, and I'm going to start sharing a lot of new stuff with you here today. So when we talk about peri-implantitis and peri-implant complications, you'll see that we have a lot of different manifestations of biological complications around implants. And they could range from anything like inflammation and bleeding and probing, as you see in this case, just recession and possibly pus, excessive edema, something that you don't really see around teeth unless you have some sort of drug-induced gingival overgrowth, and huge defects, very typical. We call them crater or saucer type defects around implants. And I'm going to walk through the new classification because gladly, for the very first time, we have a classification for these issues. And it's amazing, since the early 90s, implants are such an established and highly successful treatment modality. But for the very first time, we have a formal classification of peri-implant diseases and conditions, meaning the complications of these, in 2018. It was done at the 2017 World Workshop and was in 2018. And I had the extreme honor to be the one who authored this chapter and kind of put together the proceedings of that for our main textbook, along with Jim Heinrich. So I'm going to really walk you through how we present this in the textbook. So as you know very well, especially if you're a periodontist, you know that we've had a classification for periodontal gingival diseases and conditions, periodontitis and other conditions for a long time. And this was revisited in the 2017-2018 workshop. But for the very first time, we have a brand new category of peri-implant diseases and conditions. And this pretty much ranges from peri-implant health, mucositis, which is a reversible state of inflammation, something like gingivitis around teeth, peri-implantitis, which is a true inflammatory bone destructive disease, and then peri-implant soft and hard tissue deficiencies. So when we define these conditions, well, let's start with mucositis, okay? Very similar to gingivitis, whenever you have bleeding and probing and maybe edema in the gums, what you get for sure, these are cardinal signs of inflammation, is inflammation. But the distinction between mucositis and peri-implantitis is that we do not have progressive bone loss and increase in probing depth because of this inflammation. So you can see here, despite definitely the abundant inflammation, I really get very good bone levels around that implant. So this is a case of mucositis. This is reversible inflammation not resolving the bone. And the difference is in peri-implantitis, we're talking about an inflammatory process in the tissue surrounding the functioning implant, meaning an implant that is actually being loaded and causing peri-implant bone loss. Now, how do you get there? How can you decide if a case is reversible inflammation or destructive inflammation that really poses a big issue and might lead to complete bone loss and explantation, as in this case? Well, the answer is very simple. You got to use a probe to routinely, really, every time you see a patient for a maintenance follow-up or a 6-month or 4-month reevaluation, you really got to probe those implants or teeth. And every time I give a lecture on this topic, I invariably get a question from the audience that asks me, hey, is it really safe to use a metal probe around implants? And I will tell you, this is a classic study that was done in Texas, but not in San Antonio, in Houston, in collaboration with the Lang Group from Bern. And these folks very definitively answered this question. They got animals, they got dogs with implants placed, and they probed them, and they did sequential histology in different time points after probing these implants with metal probes, okay? And what they found was pretty clean cut. They found that even if the probe displaces the junctional epithelium, that little part of epithelium that composes the upper component of supracrustal tissue attachment, what we used to call the biologic width, might get slightly detached during probing with a metal probe, but within 5 to 7 days, you will have complete reattachment to its original position without any signs of soft tissue inflammatory infiltrate. So they said that it doesn't appear to have any detrimental effects on the soft tissue and doesn't jeopardize the longevity of implants. And this is pretty definitive. You can see a very clean histology here, no inflammatory infiltrate, PMNs, nothing like that, bone levels intact and reattachment. So as long as you have gentle force when you do the probing, and what I tell my students, what's the cutoff for pressure when you probe implants or teeth for that sense? The cutoff is clearly the point where patients don't really feel pain or discomfort. Because, you know, we have to remember that what we're probing in the sulcus of an implant is epithelium, right? It's sulcular and junctional epithelium that doesn't have any nerve fibers. So if people start feeling discomfort, that means that now the probe is running through the connective tissue, piercing the epithelium and running through that connective tissue. So this is really kind of a very clean cutoff for when you put too much pressure there. Now, I'm going to talk to you a bit about the clinical evidence that we're looking into to be able to say that a person with implants has complications that we have to manage. And sometimes it's clearly evident, like in this case where we have massive visual inflammatory changes. You see the edema here, which is about the abutment of a buccal overgrowth that is very mushy, very soft to touch. And it's clear that we have a ton of inflammation in the side, and probably we have a peri-implant complication. But sometimes it's not as easy to visually assess inflammation, and that's where we really need to assess probing depths. Now, the problem really becomes, how can we reliably assess increases in probing depths when the implants that are being placed are not placed at the same level, right? When you and I have teeth that are fully erupted and they're occluding to the upper lower teeth or vice versa, that means that we all have a normal physiological, biological width around them, right? And we know that a healthy sulcus is about 3 or 2 or even 1 millimeter sometimes. But if it's more than that, it's associated with some sort of gingival overgrowth or loss of attachment. Now, if you look at the levels here, all the healing abutments are about the same height in this case. So you can look at the vertical positioning levels and you can see that this implant was placed very, very high as it relates to this implant right here. The implant platform is down here for this implant. The implant platform is up here for this implant. So how would I expect at health to have the same probing depth if I place an implant to this level versus that level in relation to the mucosa? So of course, we have to realize that when it comes to probing depths, the number one predictor of healthy probing depth is the surgeon, the dentist who placed that implant. And let's say you have an immediate number 8 and you don't get primary stability, you have a little bit of a buccal bone dehiscence, and you make the decision to keep going and keep torquing in that implant. And when you take the x-ray, now the implant platform is at 4 millimeters below the CJ of the adjacent tooth, or at 5 millimeters. There's no way that this implant has a healthy sulcus of 2 or 3 millimeters, because if that was the case, you have a large recession, right? You have a large discrepancy to the other tooth. So that implant might start with a baseline probing depth of 5 or 6 millimeters. And that's been a major issue with assessing what's health and what's disease around implants. So the recent consensus is that in the absence of baseline records, we will consider a probing depth of greater or equal to 6 millimeters or a bone level measurement greater or equal to 3 millimeters as being periimplantitis. But the really, really favorable scenario is we have some sort of records, what I call an implant passport. And this is my friend Patricia Donas here. He came with this brilliant idea of the Swiss passport because it really gets you anywhere in the world. So we kind of need to come up with a global implant passport. And what I try to do for my patients, every time I place a dental implant, I give them a card that has this specific information: the date when the implant was placed, the brand of the implant, diameter, who the restorative dentist is, type of abutment and type of cement, if it's a cement retained abutment, which is a big predictor for implant complications, and probing depth. When I say here at loading, I don't mean at the time of implant of placement of the restoration, but hopefully at your follow-up, which might be 6 to 12 months later. And having this card, this kind of universal passport, which is identical with what orthopedic dentists do at the orthopedic doctors do at a hospital setting, right? You go in for a hip or knee replacement, even if they retire, or even if you live in a different country and you have a complication, the surgeon there needs to know what had been done before to be able to fix it and get the right parts. Same thing when we have peri-implantitis and I need to remove a crown. Worst possible scenario is that my patient had an implant placed in a different country. That implant system is not even supported in the US. I can't even identify it. And I can't really remove that crown. So chances are that I might have to explant an implant that I could otherwise tear off. So moving on to the general overview of peri-implantitis, the next thing we want to broach here is what's peri-implant soft tissue deficiencies? And really the question is, what are some issues that are implant complications, are biological complications, but are not peri-implantitis? Because of course, you know, if they're not peri-implantitis, they got to be treated very differently. So I'm going to show you here that we treated in Seattle. And you can see a couple of issues right off the bat with this case. We have an implant placed right area of number, and then we got another implant placed right here in the area of number 11 several years back. And right off the bat, you can appreciate, look at the striations of the mucosa here. Our keratinized tissue around this implant kind of wraps around the distal. We have no keratinized tissue at all over this area. And we have it's actually a fistula with a little bit of pus coming out related to this implant number 11, right? So we have a soft tissue deficiency, which is lack of keratinized tissue. And the patient has a little bit of discomfort when trying to brush that area because, of course, one of the main things that KT does for you is it provides kind of nice, stable foundation to be able to function and not have food impact on the oral mucosa and cause you pain or your brush doing that. And then you have some sort of infection here because you got pus coming out. So the first thing we do whenever we want to manage implant complications is remove the suprastructures, because oftentimes this blocks me from actually probing the way I want to, especially if the superstructure is really bulky or getting access to the implant surface. So when we do that, this was done as a resident case here, you can see clearly that the mucogingival junction has now been repositioned all the way to halfway to the crest, mid-crestal level, and that this implant really has no keratinized tissue in front of it and has this major issue right there. But you can also appreciate is how healthy the interface is. This was a very nicely done restoration. You can look at the epithelium here, the striations, you know, kind of like the little desmosomes that broke up when we removed the superstructure. So clearly there's no issue here. And when I'm probing, I can barely probe 1 millimeter, okay? So this is not peri-implantitis. But when we look around the area of the problem, you can see that there's a stoma that we can follow with a perioprobe. And what happens is that we actually bump into implant threads when we put that probe there. So that's kind of a key sign. Whenever you have an implant and you probe it either through the sulcus or through a sinus tract and you bump on implant threads, that's telling you right off the bat that you've lost bone around that implant, that you have a complication that you now have to manage. It's kind of a telling point. So here we're working with one of our residents, Dr. Vini Chu, really did an amazing job. And we thought we're going to do an exploratory surgery and at the same time fix the one problem that was clearly there, the lack of keratinized tissue, that soft tissue deficiency. So what we're doing is we're tracing a partial thickness flap because we want to be able to reposition all these mucosa high, create that mucogingival junction continuity where it's supposed to be, and then develop keratinized tissue. So you can see a partial thickness dissection right there. And that also is combined with a small full thickness flap around that implant to provide access. And take a look at this. Omid, I know you have tremendous surgical experience, so you probably know right away what this is here, but I'm going to zoom in for the entire audience to be able to see. This is just tracing the old mucogingival junction, and I want you all to focus right here and look at high magnification. If any one of you folks has ever used xenografts, all right, anorganic fine bone mineral in your life for contour augmentation, you know exactly what this is. This is residual particles of that xenograft that have stuck around in the area. And we know very well that the xenograft is osteoconductive when it's in a protected environment and you put a membrane over it and you give it 6 to 9 months to heal, and will have good native bone to xenograft particle contact, right? Osteoconduction. But the turnover is not going to be great. It's going to stick around for a long time. So if you do contour augmentation, you don't place a membrane like it was done in this case, you run the risk that some of these particles will go through repair, will be trapped in connective tissue and soft tissue. So, you know, whenever you have connective tissue and you have these acicular particles in it, there's a lot of mobility going on, micromobility. And that's a clear pathway for bacteria to get in there. So these residual particles now have hard tissue deficiency. And although it didn't start it as inflammatory, we got to treat it as, you know, due to bacteria, we got to treat it as, because now we have a sinus tract and communication with oral bacteria. So what we do in this case is we clean up, we remove all the residual particles. It was very, just scoop them out with a curette. And then we kind of appreciate the 4 millimeter intrabony defect. And this is a prototype nylon brush. The reason why we use a nylon brush is because we don't want to abrade the implant surface with a titanium brush or a titanium curette or any other instrument. And I'm going to talk more about it in just a second. But I think it's really important to maintain the properties of the surface as best as we can. So we up with this type nylon brush, and you can see the area cleaned up after removing all the soft tissue, the loose particles. And what I want you to appreciate as we're doing our free gingival graft over here, I want you to appreciate that in the partial thickness dissection, there's a tiny little bit of mucosa left behind, but you would see this is really far away from the area that I want to work onto, and that's just fine if it stays here. And this is the free gingival graft. We always do a very thin, uniform, about 1 millimeter free gingival graft, and we make sure it's smooth on the inside. It's not really bumpy to have firm adaptation. And look at the end result. This is the beginning. And here with Dr. Chu, we just use a iodine solution to kind of clearly show you exactly where the mucogingival junction ends right here. And look at the healing after. You get a beautiful area of broad KT to be able to cover your implant. You restore the mucogingival junction. But if you're critical, what happened is that little piece of the partial thickness dissection that I showed you before, that little piece of mucosa stayed behind. And it just drives me mad, because instead of having a beautiful uniform appearance here, you still have that area of mucosa in between. And it's so funny that just a little piece there of that mucosa where the cells know how to make non-keratinized mucosa, they stay around, they proliferate, and they make a little isle of non-keratinized mucosa here. So to this day, this still pisses me off, but the patient is very happy. We just kept it there. But it's just a little alarm. You want to definitely be a perfectionist whenever you do this kind of procedure, especially in the aesthetic zone. But other than that, I want to say that when it comes to peri-implant soft tissue deficiencies, I really love working with free gingival grafts, and I know they have kind of a bad history in terms of their texture primarily and the color a little bit. But I think that when done right, and when taken care to, one, position the mucogingival junction in continuity with the adjacent tissues, you know, where it needs to be, and then always make them thin and make a firm adaptation. Make sure that the inside is not really having excess areas of connective tissue or fatty tissue, but just make a nice clean cut. I think they integrate beautifully. And I see a lot of clinicians like, Dr. Musa, yourself, a lot of other folks using them with amazing results. So I'm really all for the aesthetic zone when done right. Now, moving on to peri-implantitis, we talked about it before as being kind of the mother of all evil because it's something that we can't predictably treat. So it's kind of a big, really big area that I love researching because we haven't covered it yet. So now moving on to peri-implantitis, this is how things look like. We talked about the clinical evidence before, and you kind of see all of them. You see a little bit of edema, a little bit of change of color in this area. You can appreciate how we have stippling all over this area and none over here. A little bit of a bulbous filla, and when I start probing, I have a continuous line of profuse bleeding and probing, and then a pretty deep probing depth, in this case of about 8 millimeters. And this is a case that we did in our clinic with Dr. Lee and Dr. Dobert here as part of a clinical trial we're running right now to figure out the best way to treat peri-implantitis. That was done at in Seattle. So whenever you have a disease, what you really need to do is pin down the cause. I mean, I go to my doctor. If I'm not feeling well, they're going to figure out what I have. They're going to give me the right medication. In dentistry, because medication has such limited use because of limited access to the gum and tooth area, we work with identifying the cause. For instance, in periodontitis, that's calculus and bacteria around teeth, and we do scaling and root planning to scrape off the calculus, get rid of the bacteria, and we have tremendous success treating periodontal disease. I mean, just with scaling and root planning, non-surgical treatment, right, done by a dental hygienist or a dentist, we can get up to 80% of the cases of non-molar teeth to just get better right away, maybe not even needed surgical periodontal therapy. So if we really find the cause of peri-implantitis and we fully reverse that, we should have resolution, we should have treatment. So far so good. This is a no-brainer. The problem is that we've been thinking about this very simple causality diagram since the 90s when we got the first reports. Hey, implants are not a panacea. Implants cannot get dental caries, so they're better than teeth in that capacity, but they can really get complications. And a lot of people blew the whistle in the 90s. Until the early 2000s, it wasn't really universally accepted that peri-implantitis is an issue. But recently, it has really become established that it is a prevalent issue and a big one. But I think all the major work on figuring out what causes peri-implantitis and why we can treat it is very, very recent. And I picked out 3 studies here that I think are really key, starting from 2011, 2017, that really pin down what the problem is, why we can resolve peri-implantitis. So what we're talking about is really, really old stuff here. Sorry. So let me show you how we have been treating peri-implantitis, why it hasn't been working. So when talking about etiology, because we just knew so much about periodontitis and it looked a lot like it. I mean, you have a replica of a root of a tooth, you place it into the bone like the root of a tooth, it gets bacteria around it, and this is actually an SCM image from my master's thesis where we're showing that we can have a very robust biofilm with all sorts of different rod-shaped or vibrio-shaped or motile or non-motile bacteria on a titanium surface. And you get bacteria, you get bone loss. I mean, it's so identical to peri-implantitis that even a formal statement from our academy was that we just follow the periodontal infection model, and peri-implantitis occurs as a result of a bacterial insult and subsequent host immune response, right? Bacteria trigger a host response and we lose bone. So based on the simple causality arrow diagram that we talked about before, I mean, if bacteria is a problem, the solution is very clean cut. You just need to get rid of the bacteria and you solve the problem. So what's done a lot during the past decade is that a lot of instruments were developed mostly from what we know works around teeth very well, like ultrasonic tips that carbon coated or diamond coated, or all sorts of different variations. Mechanical abrasion brushes like the titanium brush to better adapt than a curette around implants, or actual curettes that are the same thing as dental curettes, but just made out of softer titanium metal and chemicals like chlorhexidine. And what we do is we try to go in and clean off the bacteria, scrape off the bacteria in essence from the implant surface, and kill whatever's left behind with chemicals. And I tried this early on in my residency when I started first treating cases. And then this news came out, very authoritative, the Esposito group and their Cochrane systematic reviews. That's probably the highest level of evidence we have in dentistry. And it was really, Omid, it shook our world, because you get this authoritative review and it tells you existing antimicrobial driven peri-implantitis treatments have up to 100% relapse after a year. So this is as bad as it gets. Not only in dentistry, across medical disciplines. If I was going to do, like, if I had a heart stent and I had a complication and I went to my doctor and he told me, I'm going to have to change this for you, chances of survival after a year is about 0%, I probably wouldn't do that surgery. So this is kind of the same analogy here. And they that really mechanical debridement, like in this scenario, doesn't do much to treat peri-implantitis, which is completely counterintuitive to what we know. So I'm going to fast forward a little bit because I want to just give you the latest updates. And I'm going to say that we now know that peri-implantitis is definitely a multifactorial disease and can be caused by a lot of different things. For instance, if you use methacrylate cements and you have excess cement that stays behind, we know that very consistently this is going to lead to cement-related peri-implantitis. And of course, big part of this, the Wilson study has shown it very definitively. You get rid of the cement, 75% chances everything is going to get better just by doing that. But there are other cases where we don't really have a particular reason why this problem happens. We end up abrading the entire implant surface, or implantoplasty here, curettes here, and still we don't have resolution. So in these more complicated cases, why does scaling fail to treat peri-implantitis is the real question. And the first part is because of clearly, inability to clean it. When you use a curette, the toe of the curette, the tip of it, is so thick, so the instrument doesn't break, that it really cannot fit between the implant threads. The implant pitch is such that it's impossible. So you end up kind of grinding the tip of the threads pretty much. But also, we now know that no matter what you do, has surface effects on the titanium surface. And that might be kind of the little secret that we didn't think about before when we were just thinking about bacteria. So one really cool part about my job and what I enjoy very much being in academics is definitely not the paycheck. It's the fact that I can do cool stuff. For instance, I can do research about this. If I have a question, if I say, okay, what's left behind if I use a titanium curette to clean an implant? Am I really doing anything? I can take a sample of the biofilm that stays behind and I can image it in the lab. And when you use a curette, you're going to see something like this coming off the implant surface. You're going to see that you have a very robust, this is called the live dead stain, and that you see green is live bacteria. Okay, it's very simple. So you can see that you have this green bacteria fluorescing all over the place, and you maybe have a little gap here and a little gap there and a little gap there when maybe the curette touched your implant surface, but everything else is in between is live bacteria. And if you know anything about bacteria, they love to grow on implant surfaces. So I'm pretty sure they're going to cover the little spots right away. So in order to answer this, what we did is that we put together all the major ways of how people are treating implant surfaces, okay, or decontaminate them or detoxify them if you may. So you can see a control surface here. This is an implant surface that has just salivary biofilm on it, okay? And you can see that everything is green, meaning live bacteria covering the whole thing. And if you guys remember this from your undergraduate courses, this is a very simple petri dish we grow bacteria. And if I get a sample from this surface, you can see that this petri dish is full of live bacteria growing. Okay, so I know this is a contaminated surface. This is a surface that's going to cause a problem. And you see here, if I use a titanium brush, for instance, I have little patches where that is the implant surface. But when you look at these rigid titanium bristles and you magnify to look at this surface at this 100x magnification or 200x that I have here, you're going to see that this major thread is going to touch there, is going to touch, you know, this area of the implant, and then it's going to touch that area of the implant and that area, and anything in between is going to be untouched and maintain a thick biofilm, and we can grow bacteria out of it. And you see, when I start using a nylon brush that has more bristles and can conform better, things get better. I still have live bacteria. It's just that they're not all over the places they are in the control surface, and they grow a little bit less over here. And when I use chlorhexidine, that people think, hey, you know, chlorhexidine is pretty cool because it kills bacteria. I'm going to tell you, chlorhexidine does two things. First of all, it doesn't kill biofilm bacteria very well. We give chlorhexidine after a surgery when we've cleaned up because we want to prevent biofilm from forming. But if you have periodontitis and you give someone chlorhexidine washes without ever cleaning their teeth, that's not going to do it. Chlorhexidine cannot penetrate the biofilm. And you can see using chlorhexidine and actually rubbing it on the surface, which is what we did here, doesn't really do a lot to remove the biofilm. And you get a lot of dead bacteria, these little orange dots all over the place that stick around. And we all know that dead bacteria, their LPS, their endotoxin, if they're gram-negative, stay around. And that's a big problem that can trigger the immune response as well. And then lo and behold, I get the most simple solution that I could ever think of, which is pressurized saline on an implant surface. We started this study, this project, by using the pressurized saline more as a control, because clearly we know that saline doesn't have any antimicrobial activities at all, right? And we just use this pressurized saline group, and we provided the pressure by using a water pick, kind of a water jet, and we sprayed the implant surfaces, and oh my gosh, this was like pressure wash in the backyard. It took away pretty much almost all the biofilm. You see a colony remaining here, a few little colonies remaining there in low and high magnifications, and not being able to regrow any significant amount of bacteria on the surfaces. So this was a game changer to us. This study was just published in the Journal of Periodontology, and it really made me start thinking implants and not teeth. So our peri-implantitis treatment approach now is really what we call implant-specific periodontitis treatment. And this is because we want to focus on what are the characteristics of the implant. What is the problem? Do we have biofilms forming on the implant surface, and biofilms are just, you know, sticky mucus layers of bacteria? Or do we have large chunks of mineralized calculus? And we know very well that calculus is not a major problem. It's very uncommon, actually, around implants. So do we really need these abrasive devices that don't remove biofilm very effectively on the implant surface? Like, do we kind of need a hammer to kill a fly in this case? And if we do that, what's the problem that might come up? And what you see here is an implant surface. This is a flat implant surface, a titanium disc that has sandblasted and acid etching on it. And we use one of these titanium brushes. And what we find is that this is a high magnification. This is an X200 magnification of this implant surface, how it's micro rough. And this is how the implant surface looks like after I apply a 30-second cleaning of that implant surface. Who would ever imagine that titanium against titanium can cause so much direct degradation? And you would think that I can flush this away, but I will tell you that from human studies, it seems like if I damage that surface, a lot of this is going to end up in the plaque around the implant and in the tissues around the implant without me being able to just flush it away, unfortunately. And when we compared, as part of our study, we said, okay, I know that some of these modalities have a mild antibacterial effect, some have a better one. But what really happens in terms of adverse events? what if I clean the implant surface with these mechanical approaches and I remove a little bit of the biofilm? That's better than doing nothing, right? But what about if I cause an adverse event to happen on the surface? And what you can see here in this graph is us measuring how much titanium particles we had not breaking down directly as a result of cleaning from the implant surface, but breaking down in artificial saliva over 30 days in aging conditions. And you can see that this group outperformed all other groups, and this is the titanium brush treated group, where treating that implant made it leak titanium from its surface, caused titanium dissolution over time. And you can see the massive titanium aggregates in artificial saliva over 30 days. So this is just a vial with artificial saliva, but imagine that in reality, what you've done when you're cleaning an implant with an aggressive metal instrument is that you break down the titanium dioxide layer, the passivation layer, so the implant is not protected from corrosion anymore. So you start having implant breakdown in the tissues. So the question is, how cytocompatible is this anymore? And I want to show you how this has really made us transition. This is part of one of the hands-on courses that we're doing on implant cleaning, and how it's kind of changed our thought process, and we're experimenting with non-surgical treatment of implants of peri-implantitis with just pressure saline. And I will tell you, the results are at least as good as mechanical treatments. And you can see right here that we're using kind of a chairside water jet device. This is just showing the defect. And this could be, as simple as it looks, this could be probably the most effective way that we have right now of removing biofilm non-surgically from implant surfaces. So as a matter of fact, this could be the non-surgical peri-implant of the future. This very simple intervention, just pressurized water, is more effective than any abrasive we have tried to clean the implant surfaces from biofilm. So this really requires thinking outside of the box. And when I told you about these studies that I think have really changed the landscape of peri-implantitis treatment, I got to mention this article from Megger et al. From Div that came out in 2017. And what these guys did is something very simple. They used an ultrasonic tip that we all have used, and clearly before getting into peri-implantitis research and during my training, I did use an ultrasonic instrument to clean an implant surface in peri-implantitis, and I think most people would have done it because we didn't know what the adverse events might be. And you can see here, this is what the situation looks like if I assess the water that's coming out of the ultrasonic for after 30 seconds of treating an implant surface. You can see all these particles being collected, right? Just by a 30-minute abrasion of that implant surface. And you can see here that when one quantifies them, you have about 3 to 4 million of these particles, 3 to 4 million particles coming out. I mean, this is mind-blowing. Coming out after the use of an ultrasonic tip on an implant surface for 30 seconds. And what these folks did that I think was just extremely smart in terms of a study design, they collected these particles and they implanted them in a mouse model of bone destruction. Okay, so they injected these particles in the back of the mouse near their spine. And this is how the control area of the bone looks like. And this is pretty good quality lamellar bone, right? You can see the mineralization here, you can see the lacronite, everything's good, right? This is the control group. Now they inject these particles and look at what's happening here. This is war. I mean, these are osteoclastic resorption pits all over the bone. And you can see the particles here in the proximity of these resorption pits. So when they compare that with LPS, and we all know LPS, the endotoxin from the gram-negative cell wall of the bacteria, is a very potent inducer of pre-osteoclastic maturation. So if you get LPS and you feed it to pre-osteoclastic cells, then they're going to differentiate and they're going to start having a phenotype that can eat a bone. And look at that. Titanium particles have a greater effect even than LPS in terms of the number of osteoclasts. I mean, when you think about proof of concept, this really changes our entire thought process about how to clean implants. It requires us to think outside of the box real hard at it. And it has made us transition our thought possibly away from the periodontal infection model. And what if an implant degradation model kind of suits the whole hypothesis of peri-implantitis better? And this is not to say that bacteria are not a big part of the problem why we lose bone. I mean, absolutely they are. But there's an additional factor, kind of a co-contributing factor, and that could be the titanium breakdown. And I'm going to tell you a massive argument. There's a lot of work from the Albrechtsen group and from a lot of other folks that have been talking about titanium breakdown for a long time. And I think reality is that if we take this camp of people talking about titanium breakdown being a problem in titanium particles, there's a recent very nice review about it by Danish Tarnow and Will Ginobili and Homely Wang at the Journal of Dental Research, people I respect a lot, where they're putting really good arguments in favor. Take that and you bridge it with what we know about oral bacteria and how they colonize implant surfaces, and you put two and two together. That's really, I think, the way of the future about treating peri-implantitis. And I'll give you an example. I just love this image because it tells you a lot of different things. First of all, if the bacterial only entity like periodontitis, which really affects the majority of your dentition, the majority of cases of periodontitis is generalized periodontitis affecting all of your teeth. How is it possible that I have a primarily bacterially driven disease here and I have massive bone loss around that implant? Not only I have 50% bone loss, but at the same time, I have this huge crater forming around this implant. Look at, volumetrically how big this defect is. And at the same time, it stops right here and it's being bordered by good healthy bone surrounding this implant. And yeah, I have an implant thread exposed here, but at the same time, these implants have been in function for a long time. And this is a platform matched implant design. And I expect some of that initial crestal loss to occur. But look at the stability of the bone around this implant and look at this entire huge defect around that. If it's bacteria, how can I really retain bacteria over that implant for so long to cause this distraction and just not jump on the other side? So this is just a really interesting argument. And I'm going to show you that using this concept of, hey, let's see how we can restore the compatibility of the surface or maybe maintain it, how we can get from this huge defect, and you can see here, returning back after treating this case with a partial thickness flap because we want to do some soft tissue management in this case, and put in our probe here, we have hard tissue underneath this periosteum that's exposed here, and we've recovered this implant all the way up to here with new attachments, right, which is kind of impressive. So how can we really treat this implant in a way that we not only remove bacteria, but we maintain the properties that in the first place make this implant surface biocompatible and cytocompatible? So kind of a brief overview of our process, especially back then. This is one of the very earlier cases we had when we were starting. You can see that you open up these defects and you have massive granulation tissue around it. And the reason why you have that is because they progress so much faster than the periodontal defects, that the demineralization happens straight, and you still have some of this collagen, the organic matrix of the bone, staying behind. So we oftentimes use a curette to clean this up, but I'll tell you, Omid, we never use the curette to touch the implant surface. Whenever I'm using this curette, it's always, the cutting edge of the curette is always facing the bone and away from the implant, in a way that I know that I can really release the granulation tissue in one piece as if I was removing like a from the bone, but at the same time, make sure I don't damage the implant surface. And you can see here, we pretty much remove this in one piece around the implant. And then the day using cotton pellets with saline as a proof of principle. And the proof of principle was, okay, from all these studies, we know that biofilm is not that hard to move around the implant, and I don't need a hammer to kill a fly. So what if I just use sterile saline, something that everyone made that non-antimicrobial in itself, just remove biofilm by burnishing it away, and then be able to regenerate bone. So you see me burnishing the biofilm, just look like after removing granulation tissue and cleaning it. Uh, Sorry. And moving forward, this is really intramural perforations all over into the bone here because these, and inside the intrabony defect, because these defects are some of the hardest ones to manage. Limited blood supply and titanium surface is not a cytocompatible anymore. So it's way more challenging than actually doing a GBR procedure because you also now have an implant surface that doesn't get any blood supply and it's not as cytocompatible as it used to be. And then because we were doing a proof of principle, we wanted the real heavy, the real osteoinductive material that we had back in the day, and that was infused. And as you know, infused dominant human BMP2, absolutely proven osteoinductive material. So we put that in the defect. Of course, that's becoming now a very expensive, right? But at the same time, this is proof of principle. And here we get the standard very hard edema that lasts for about 10 days. If you guys have ever used infused, you're familiar with this. Nothing to really scare you off as long as you expect it. And this is showing you how we transition from this very large defect, about 10 of the implant, look at how massive the extent is, to this situation at uncovering, because I have to tell you, we really go for a primary closure of the disease. Uncover, you get new tissue. This is after doing a pharyngeal graft, removing the suture and allow the tissue to heal to get some keratinized tissue here where we didn't have any. And the true testament here is time. And you look at the x-ray taken 3 years later, and you see that we were able to rebuild a large part of this defect right here. We were able to rebuild this entire part right here, which accounts for about 60% of the defect. And of course, we still got 3 to 4 threads of the implant exposed, but it goes without saying, whenever I regenerate tissue around a tooth or an implant, there's no way I can get 100% of it, especially in such a massive defect, and get it to stay. Around teeth, we know we can regenerate 60 to 70%. Here we regenerated 60 to 70%. What really matters is that at 3 years later, I don't have relapse. I have a stable condition. I have soft tissue stability. Obviously, in this area, does have connective tissue attachment, and then I have bony support. So this implant is not mobile, doesn't have signs of recurrent disease. This is an implant that will stay there healthy for a long time. So this is what I consider a successful treatment. And I'm going to wrap up this presentation by telling you that we've now optimized and transitioned this protocol to make it, and we have distinct steps that we use, and we're going to go, courses we go over every step in detail. Here I'm going to just summarize the major ones, but I'm going to tell you that we've transitioned to things that we found have really worked, and we try to keep the cost down. So BMP2 really works very well in our hands for regeneration. The challenge is that sometimes this peri-implantitis treatment ends up being more expensive than augmentation and implant placement in itself. So we've now transitioned to biomaterials and combine with autogenous tissues that work well and kind of keep the cost down, because what a patient that has paid a lot of things and has gone through a lot of stuff to get an implant for function and aesthetics in the first place doesn't want to, is pay even more to just now have to maintain this implant, possibly even after just 2 to 3 years of function. So this is a case from our ongoing peri-implantitis clinical trial with Dr. Lee and Dr. Dober treating here. And this is the implant in question. And you see that when we remove the implant restoration, you immediately identify some sort of fragment in the area. And when we remove that, this is clearly excess cement. It's not calculus, nothing like that. It's just excess cement. And always makes me happy when I find something like this, because I know I'm part of the problem. And removing that will help make things better. So what we do invariably for every case where we can remove the crown is remove it and put a cover screw. And I call this pro bono soft tissue augmentation. It's the best soft tissue augmentation you could do ever in your career, I think, because first, it's free. You just let nature take its course, and it's so predictable. So by putting a cover screw over the area where I have a little bit of connective tissue exposed, the tissue is going to spontaneously grow over this area. and cover, and what I've gained in this case, without doing anything else other than putting a cover screw, I've gained all this area of high quality cartilage tissue now that will allow me to predictably get primary closure over my implant. And then I'm going to show you a little video. This is a case treated in our graduate periodontics clinic with Dr. Arzuman here in San Antonio of how we treat the implant surface. And you see that, again, here, because of our study, we're using a prototype nylon brush. And the reason why we do it is, again, because we don't want to have these particles going into the tissues after we perform the procedure. And as part of this procedure, you see that we were able to clean the implant surface and and be able to into intrabony defects. So the concept here is, how can I perform a minimally invasive strategy that we will be able to remove biofilm from the implant surface, but at the same time really be able to get rid, to maintain the titanium surface properties. And in addition to using our nylon brush, you will see that in this case, a secondary thing that we do, we've transitioned away from the cotton pellets, and we're now using gauzes that really don't fray as much as the cotton pellets, and they don't leave debris behind over on the titanium surface. And we kind of use a shoe shine approach, just saline, really use that shoe shine approach to be able to clean the implants. And what you'll see here is a burr, but not for the intent of doing implantoplasty, but for taking care of part of the problem that was the inappropriate contours of this crown that were extending really too far submucosally and being an issue of retention. So you see this area of the crown being adjusted, and now intraoral polishing, and moving on to go ahead and do our augmentation and get a membrane in place and move ahead. So when you look at the materials that we now use, we've really transitioned to materials that can, as I said, keep the cost down, but really get the job done, because these defects are very, very easy to treat. And the problem with this is that the issue with the defects is very, very limited blood supply. I mean, look at this complete lack of the buccal plate. Look at this implant right in here that impedes any vascularization from these walls. This is a very challenging defect to treat. So we've shown in preclinical studies that osteostimulated biomaterials or osteoinductive biomaterials, like infused with BMP2, DFDBA from young donors, which is osteoinductive, or calcium phosphosilicate, like the dental morsels here. These materials all have a capacity to either signal induction of these progenitor osteoblast molecule, osteoblast cells, to turn into function in osteoblasts. In the case of osteostimulated grafts, to just attract more progenitor cell populations in the area. And because we need some osteogenic potential, I've kind of fallen in love with these instruments that works terrifically in my hands. This is a micro-os. It's a little pen-size instrument for local autogenous graft harvesting. And whenever we needed to get autogenous chips from the area, we used the safe scrapers back in the day, but they pretty much require a secondary access in the back. And that's been a great problem for us. But at the same time, we have now the ability to just go locally in our flap and be able to use the micro-os to get the autograft particles. And of course, we always use a membrane to submerge these cases. So I want to show just one more case of how this is treated, and then move on to our discussion here. So you can see an area where we're entering the defect, being able to collect. This is the little stylus pen-like instrument that can go underneath the flap and get these autogenous bone chips right off the bat. And then move ahead and graft with particles the entire defect. We never want to overgraft and be greedy, because I know very well that I cannot get bone to stick all the way up to here. What I really know how to do is get the bone to grow to the level of the adjacent bone. So we're going to clean up the extra particles that are over here. We're going to lay over a membrane and go for primary closure. And this is part of the study. So I'm just going to show you a 5 months post-surgical result where we start from an 8 or 9 millimeter primary pocket with bleeding and probing, and we get a little shrink and see how the edema is going now, and we're back to a healthy 3 to 4 millimeters probing depth at the early follow-up. So this is really what we want to see in these cases. This is really good progress being made. So that being said, I'm just very, very enthusiastic to hear what you say, Omid, and kind of get your take on how to be able to really incorporate this new thought process in our daily practice of maintaining and hopefully being able to successfully treat implants.
Thank you so much, Georgios. First of all, I have to say that it was one of the most beautiful presentations on peri-implantitis I've ever been or I've ever seen. I congratulate you, very detailed and very well presented. I think all the audience have enjoyed it so much. And before I go to the discussion, I personally want to invite you to join me very soon at the Symposium of Complications, because I think we need you in Tehran for this event and for this topic. So I want to just invite you from here, from this platform, and soon you have to promise to come to Tehran for the event.
Hey.
Yeah. And
it'd be a terrific pleasure.
Thank you so much. Pleasure is all.
I don't know. Sorry, I had a little lag there, but yeah, absolutely. Absolutely.
And yeah, so before we go to the discussion, I just want to all the audience to know that Georgios is going to have a great presentation at the PICO Symposium this October. So for those of you in the United States or those who are able to fly there nowadays, I really encourage you all to join this event. Great speakers like him, and it's definitely not to be missed one. So Georgios, actually, I have many questions. I don't know if I have enough time, but I try to do my best. As I got the point right, and I really like the article that you showed how different cleaning methods can have an influence on the titanium surface. And what was interesting, the ability of saline, and with the pressure that we can clean it and almost no bacteria was left, was very, very interesting for me. So is it right to say, with all these things that you presented for us, that implantoplasty is not a good treatment option?
So Omid, I think you bring up a great point, because we've been doing implantoplasty for some time, and I think to answer this in a fair manner, we have to kind of classify the defects. So I really like the article by Frank Schwartz from Germany, where he classifies class 1 and class 2 peri-implant defects. And for folks in the audience that are not familiar with this, class 1 would be the horizontal defects, meaning implant threads that are now exposed above the bone level, and class 2 with the different classifications would be the intra-bony defects. So in intra-bony defects, which is pretty much what I'm working on and what I'm showing you, we have a unique opportunity to regenerate them.
Mm-hmm.
So I think, as far as I'm concerned, the data overwhelmingly says that we got to think twice before doing implant in the intra-bony component of the defect, because you really spread these particles. I mean, I've done implantoplasty twice in my life, and if you've ever seen this, you can see the bone turns black after you do that procedure, right? It turns gray black. And there's no way, no matter how hard you apply saline around, there's no way to remove the whole thing. So to me, based on the data that we have, it's a no-brainer. Now, the times where I've done implantoplasty is for horizontal defects, especially part of kind of a multi-implant restoration, like a fixed detachable, where we can apically position a flap and keep that implant there, hopefully long term, because there's no intrabony component, and the bone loss is not that extensive. So there's kind of an opportunity to do implantoplasty just for the horizontal part, but I would say that it's very, very limited, especially because no matter how meticulous you are, if we're able to get a small microscope, or maybe like a dental microscope, the one we use for soft tissue procedures, and do a 10x magnification, you're going to see that the area you leave behind is far from smooth. How careful you are, it's just impossible. So to me, can you keep it plaque free if you do implantoplasty? I just have doubts about this. So in my hands, it don't work very well, but even in the hands of others, I'd say possibly for horizontal defects, clearly not for intrabony defects.
Yeah. So you mentioned a very good point, and that was the topography and morphology of the defect. Regarding the classification by Frank Schwartz was very actually simple and straightforward between the horizontal point and the intrabony point. And also a recent publication by Alberto Monge, we have different type of defects around implants regarding peri-implantitis. And what you noticed was interesting, that you are working on a contained defects around these implants. So you have some bony walls that helps you, like intrabony defects, to build up the bone. And you really showed the techniques and easy techniques to clean the implant surfaces. Now I want to have this question. Sometimes we have lost bone from the buccal side and from the lingual side or palatal side, but we have a little mesial and distal walls. So in those cases, do you prefer, again, to try to clean the implant surface and at the end maybe gain only soft tissue attachment to the implant surface, or you prefer to remove the implant, do the reconstruction, and come back and place the new one?
Well, that's a great point, and the best answer I can give you is that I don't know. That's the most answer I could give you. The reality is that there's still no rule of thumb for when you can treat an implant. The only real rule of thumb is that if you know that over 50% bone loss, likely that implant is soon going to get mobile. And if it starts moving, then it's of course beyond repair. We know that when there's less than 30% bony support left, likely this implant is going to now start moving. So we've done some really extreme cases at 50 or 60% bone loss, and we've had one complication once that during healing we started having mobility of that implant, and of course had to explant. But I think with what we know, as long as this is a defect where you would feel comfortable performing guided bone regeneration, if an implant was not there, okay, that could be a defect where, as long as the implant surface has not been damaged and the implant is stable there, that is likely a defect that you can still perform guided bone regeneration with the implant in place, which is in essence peri-implantitis treatment, because treat guided tissue regeneration, no real tissue attachment to that implant, it's just a direct bone to implant osseointegration. So I'm very familiar with Alberto's work, and I think he has a very nice comprehensive workflow, and he really sees the bigger picture. And the Home 1 reviews and all, they see the big picture and they try to cover all the different issues that might come up. My work is mostly focusing on regenerative work around bone regeneration around implants. So I'm mostly focused on these defects where have a big impact and save implants. And what I'm getting out of this work, and by the way, what's very important and meaningful to me is whenever we do these very nice sessions with experts like yourself that have excellent reads, then the audience gets back and they kind of share their cases of success using our specific treatment protocol. And that to me is the most important thing, because it's external validation. I don't want to be doing something that just works in my hands and in my clinic and just doesn't work for anyone else. So when we get to that, the real question is, do you want to tell your patient that it's more predictable to explant the implant and start all over again and get into a process that will take, when you talk about explant, GBR, implant placement, and new loading, you're talking about a 6-8 month process at the very least.
Yeah.
So do you want to do that, or do you want to tell them what I do? And that's my rule, as long as specific indications, which means that we have intrabony component, the implant doesn't have mobility, and the implant has not been treated in the past with implantoplasty or abrasive mechanisms such as curettes to be able to clean that implant, meaning that I still have an osteocompatible implant surface. I tell them, we give this implant a chance.
Mhm.
It's probably going to be a 50-50 chance, but this is what I can do for you. This is what it's going to cost. And in 6 months from now, I'm going to be able to do an uncovery and tell you. And I will tell you, patients are very, very passionate about keeping that implant. And I've really tailored my practice to be focused on these procedures. And we have pretty good success, which is more than 50-50, but without me having the human data long-term to say that it is more than 50. I'm just going to keep it to that because it's more fair to the patient to under-promise and over-deliver.
Yeah, good point. And you know, I see many patients that come to us, maybe some of them my patients, some of them by referral. And when I evaluate the patient, I see many implants that have lost the bone, maybe 6 millimeters, 7 millimeters, but we don't see any sign of inflammations, any sign of color change, any bleeding, and they're not very easy to probe. We can probe them, but not easy to probe, maybe a little pressure, which I think when it's not probable, I think there is no need to put pressure on it. So what's your thought on that? Because many dentists around the world, I've seen that, think that when they evaluate the radiography and they see some bone losses, that's peri-implantitis. But I think we should take that into consideration that sometimes bad implant positioning, not enough bone thickness around implants, or not enough soft tissue, or bad depth can cause bone loss. But sometimes when the tissue is healthy, we have soft tissue attachment to the implant surface without any disease formation. So what is your thought on that? Do you think that it's necessary whenever we saw or we see huge amount of bone loss, but with no signs of inflammation, should we re-enter the case and do something, or should we just put the patient on the follow-up?
Well, it's very individualized, I want to say, and to me, the most important is appropriate diagnosis. So, I've showed you classification-wise. I showed you before that the new classification has specific guidelines for what is periimplantitis, and they tell you that in the absence of a long-term baseline and follow-up record, if you have at least 6 millimeters of probing depth, 3 millimeters of bone loss beyond crestal remodeling, and bleeding on probing, that's periimplantitis. Now, if you're missing one of these things, the best thing you could do is try to get as many baseline records as you can. So we now know that if an implant is placed in a position where you have a greater than 30-degree emergence angle towards the conic point, that puts it at risk for periimplantitis. Or we know that if it's placed too deep, you can start with a baseline 6 millimeter probing health. So in cases like that, you really have to see what's part of the problem, and is it really inflammatory? I mean, you mentioned there's no inflammation, we can't probe. The kind of the pathognomonic feature that I'm looking for there is, when I probe to the extent that I can, do I feel the implant threads inside? If I feel the implant threads, I know that I have true bone loss. So the next question is this progressing or is this stable? Because if I have a case that for a reason lost bone that was not due to a chronic inflammatory process, I'm not going to go in and damage that, because I might actually do more harm than good. So sometimes it's hard to guess what the real cause of the problem is. But I will tell you, if we want to capture the causes that might lead to either a peri-implantitis defect or a peri-implant hard tissue deficiency, which is fundamentally different. If we want to capture the 360, we got to get experts that start all the way from the crown to the bone. And we recently, I had the pleasure to be in a symposium with Rick Myron and Yanni Vergulis and Tom Linkovich and myself. And I really enjoyed that we put little pieces of the puzzle together, and we talked about we talked about emergence, we talked, zero bone loss concept, and what I'm doing with the titanium surface preservation, and putting it all together, you get just a much better perspective about what you need to investigate. But it's clearly multifactorial, and if I don't have these three components that we thought, I really wouldn't jump the gun and go in and treat that.
And Georgia, even in those cases that the implant is superficial, for example, a patient is referred to you and you see the peri-implantitis, and in your evaluation, you see that the implant was placed too superficial comparing the adjacent teeth. So what about those cases? I mean, the problem is not only the peri-implantitis. The problem was also bad positioning and or, for example, you showed a bad crown contour and you decided to change the contours. That was fine. But what about the bad implant positioning? Will you also try to regenerate the bone in those cases and save the implants? Or when you see other etiological factors for this problem, you decide to change the scenario?
No, I totally agree with you. You see this being problematic to begin with, and what caused the problem, I mean, you just stated that, what caused the problem is there, and no matter what I try to do, the problem will remain there. So that's a no-touch case. That's clearly, as you said, that's an explant case.
Yeah. Well, thank you so much, buddy. I have to say thank you so much for your time, for this beautiful presentation. I truly enjoyed it. And as I said, I'm really looking forward to see you soon, wherever in the world is possible, but definitely in Tehran. And thank you. Thank you for accepting, and stay safe, my friend.
Well, absolutely, my pleasure. It's the hot seat is really the place to be, and I hope that we're going to have great feedback. And if everyone has questions or wants to touch base, they know where to find me. It's been the utmost pleasure, and I want to thank you for all you're doing to keep us all, including myself, educated on the cutting edge on so many beautiful topics on implantology. It was a pleasure, Omid, and thank you very much.
Thank you so much.
You take care.
Bye-bye.
Bye.